So what is our experience in low-dose prophylaxis in my country? This is my disclosure. So just for the beginning, for those who didn't know Tunisia, Tunisia is this little country in the north of Africa where we have only 3 main departments of hematology, one for people in the north, the second for the center, and the third one for the south. Tunisia is a country with almost 11 million inhabitants with an area of about 164,000 square kilometers. And to my knowledge, now, today, the NMOHA has identified 497 people with hemophilia. So I belong to the center of the north, where we have almost a little bit more than half of people with hemophilia in my center. So we started with the low-dose prophylaxis since 2007, and it was introduced step by step. So in the beginning, it concerned children, and it concerned children with frequent bleeding. Then, when the experience was successful, we extend the experience to all children going to school to have low-dose prophylaxis. And then we start also to improve our practices, and we tried to start earlier as possible for all children just after the first or second joint bleeding. On the other hand, we had also introduced low-dose prophylaxis for some adults with frequent bleedings. So the protocol we adopt for this low-dose prophylaxis for hemophilia A was a once-week injection or a twice-week injection according to the facilities and according to the venous access. So the evaluation is essentially clinical. If there is no bleeding, we continue with the same protocol. If not, we try to adopt by moving to a twice regimen, and if not, to a 3 injection schema with 10 to 15 units per kilo. For hemophilia B, it's almost the same. We start once weekly with a slight higher doses of 35 to 45 units per kg once a week, and a clinical evaluation. If there is no bleeding, we continue with this protocol. If not, we move to a regimen of a twice injection schema. Our results were presented in 2014 in Melbourne and published in Hemophilia in January 2017. And we clearly demonstrate in this paper for children where we started with a median age of 5 years, we clearly demonstrated that we used a median weekly dose of clotting factor concentrate, which is around 30 units per kg per week, and the dose per injection varied to between 8 to 30 units per injection according to the regimen of once, twice, or 3 injections per week. What we clearly demonstrated in children is that with a low-dose prophylaxis, we are able to reduce the number of annual bleeding, if not to disappear totally the bleeding event, with a significant difference between the number of annual bleeding before prophylaxis and after prophylaxis. We also demonstrated a stability of the hemophilia joint health score, which was one of the assessment tools we used, and an adequate functional independence score in hemophilia. On the other hand, we also have observed a decrease of the absenteeism in school and improvement of quality of life. For adults, the data were not published. We had some results for a cohort of 13 adults with hemophilia, where the consumption were around 1,000 to 2,000 units per week, which correspond almost to 15 to 30 units per kg per week, and with a median dose of 2,000 units per week. 24% of adults receive a once-week injection. The majority receive a twice-week injection, and 28% 3 injections per week. We started for the majority of adults at the median age of 22 years, and we clearly also demonstrated a reduction of the number of the annual bleeding with a significant difference between the number of bleeding before prophylaxis and after prophylaxis. So today I will try to give you an update of our results. So it's clear for us that prophylaxis and low-dose prophylaxis in our country have the main goal of this treatment is to prevent the joint disease, and so the handicap of mobility. The assessment tool on which we stressed on for following our patient was the Hemophilia Joint Health Score, which is a cheaper assessment tool. And we need also a trained physiotherapist for that. Some patients underwent ultrasound exam, but I don't have enough data to share with you today. So the number of people with hemophilia in my center today, according to our registry, is 250 people with hemophilia. From those people, we have 23 that are not seen regularly, and 227 who are seen at least once a year. From those, we have 145 adults and 82 children. What is the proportion of children and adults today on low-dose prophylaxis? For adults, we have 38 adults with hemophilia on low-dose prophylaxis, which correspond to 26% of our adults. And for children, we have 58 children on low-dose prophylaxis, which correspond to 71% of all children with prophylaxis. And the 24 children who did not receive prophylaxis are 9 new patients who are still, let's say, on demand, but they didn't bleed, they are a new diagnosis, or they experience a mucocutaneous bleeding, and 9 other are children with a minor hemophilia, and we diagnosed 6 children who developed inhibitor. So if we exclude the mild hemophilia and the children with inhibitor, we can say that 86% of our children are on low-dose prophylaxis today in my center. So this is a distribution according to the type of hemophilia and the age. So adults more than 18 and children less. So for people, patient with hemophilia A, we have 45 children and 27 adults. For hemophilia B, there are 13 children and 3 adults. And I will start to show you the data for hemophilia B patient. So this is a schema of the Hemophilia Joint Health Score for the 13 children with B hemophilia. And you can see that the majority, if not all the children, had a Hemophilia Joint Health Score, which is quite stable and which is less than 10, which is one of our major goals. Only one have a Hemophilia Joint Health Score, which is superior to 10. And the explanation for that is that this is a hemophilia B children who developed an inhibitor, and so a replacement therapy is not so efficient. He still receive a regimen of substitution, which could correspond to an ITI with a low doses, but for bleeding event, he received bypassing agent. Now for the 3 adults with B hemophilia, we have 2 adults with a Hemophilia Joint Health Score less than 10, but they are adults who started prophylaxis when they were children. And for the other patient, the hemophilia joint health score seems to be quite stable, but he starts at the adult when he was an adult. Now, what about the hemophilia A? So 45 children and 27 adults. For children, you have here a summary of the evolution of the hemophilia joint health score, and you can see that a group have a score less than 10, and some patients had a higher score. The first explanation is the age when we start prophylaxis. But I would like to illustrate some of them with a higher score. So this first patient is a children, but with other comorbidities. He developed an inhibitor. He received induction human tolerance with a successful result, but he also have a dislocation of the hip, and the parents disagree with the surgery. For this one, this is a teenager who stopped prophylaxis during 1 year. And finally, here you can see also two teenagers who have a score who was increased, and we tried to discuss with these two teenagers who receive a prophylaxis not regularly and who have higher activity, and we try with them another protocol, another approach to give them 500 units each other day, and it seems to be efficient. Now, what about the data of the adult? So this is the data for hemophilia A who are 18 or more. So you can see that also here we have a group with a hemophilia joint health score which is less than 10. And the explanation could be that those adults started prophylaxis during childhood or during childhood. Now here we have another adult with an increase, a very important increase of the score, of the hemophilia joint health score, and also we want to understand why, but the explanation is clear. This patient suffer also from another disease, which is a bipolar disorder, and he experienced a lot of trauma. Here again, two adults who have increased their score. They were two brothers with a lot of difficulties in their families, and now they receive a prophylaxis. The hemophilia joint health score seems to be stable, but at least we have an explanation. So how do we learn from this data? First of all, we try to adapt the protocol by the activities. It's clear that the patients are not the same. We try to perform a very close monitoring with education. It is very important that people with hemophilia, parents and children, understand how the low-dose prophylaxis work when they have more factor 8 or factor 9, and they can have minimal activities when the trough level is down and they must not have hard activities. Physiotherapy is very important, essentially for strengthening but also for monitoring, and it seems that the low-dose prophylaxis can stabilize the joint disease. What about starting earlier in children? So to start earlier in children, that means primary prophylaxis, we have some data for that. So it concerned only 16 children. We have 24 children who started earlier prophylaxis. They are 18 hemophilia A and 6 hemophilia B, from which 3 developed inhibitors. So we have data for 16 children who started low-dose prophylaxis earlier. Here is the data of the hemophilia joint health score. So we have here a children who increased his hemophilia joint health score, and we tried to understand. He experienced some bleeding event with sometimes irregular prophylaxis, that could be an explanation. On the other hand, also we have 2 others who still have an hemophilia joint health score which is less than 10, but we try to close monitor those in order to prevent joint disease, and with the education, with the support physiotherapy and the strengthening physiotherapy, we hope we will be able to have a score which will be always less than 10. What about the individualized therapy? It's clear that there is no single regimen to be proposed to everyone. We start with the same protocol, but then we adopt according to the clinical data and according to the patient. Many aspects nowadays are individualized in prophylaxis, and it is said that treatment must be tailored and adapted to the patient activities, to the bleeding phenotype, to the compliancy, to the pharmacokinetic, and I'll add also the availability of a clotting factor concentrate. Okay, tailored prophylaxis, we consider so the bleeding phenotype, the physical activity, the pharmacokinetic data, but also the availability of a clotting factor concentrate must be considered. We have some preliminary data, but no results, so the evaluation is essentially clinical discussion and participating the patient and the families. And for the pharmacokinetic data, we don't have really pharmacokinetic, but we were interested in the trough level after 1 day, and now after 2 and 3 days in order to understand, and some data on the ROTEM for thromboelastography in order to understand why people are not all the same. So as you know, the pharmacokinetic differs from one patient to another. You can achieve a trough level of 1% after 2 days or after 4 and 5 days for 2 different patients with the same doses and the same weight. So we have some data for some teenager receiving low-dose prophylaxis, and we try to see the trough level after 1 day, and you can see here that there is the results are very different from one patient to another. For the ROTEM also, you have here in the upper schema, so the aspect of the ROTEM before the injection, the dose of a low-dose prophylaxis, and after. So what is clear that for all patients we were able to reduce the time of the coagulation and to improve the maximum clot firmness, whereas the data seems to differ from one patient to another. Now, what about the other center in Tunisia, which was a big challenge for us? We are very happy that the other center also started prophylaxis, and to my knowledge, in the south, where 124 people with hemophilia are followed up, 25 of them are on low-dose prophylaxis, and in the center, from 100 people with hemophilia, 10 are on low-dose prophylaxis. So now to conclude, first of all, for children with a low-dose prophylaxis, it's clear that we are able to reduce the bleeding, if not to disappear. It is better to start with a low-dose prophylaxis if you don't have enough clotting factor concentrate than giving on-demand therapy. It is sure, but it is efficient, but it should be adapted in different cases. Education with a low-dose prophylaxis is very, very important. People and families must understand how it functions. You must also consider the activities of patients. A close monitoring is mandatory to achieve good results. And the aim for us, giving this regimen of treatment, is to try to prevent the joint disease. What about adults? For the adult, it's clear also that we were able to reduce the bleeding event, but it seems that we can stop the evolution of joint disease. It's not well demonstrated, but it seems that it is stable. And it seems also that we were able to improve quality of life. So our evaluation is essentially a clinical evaluation. So it is cheaper, we don't need money, we need time, and we need to consider people with hemophilia and families. So prophylaxis with a low doses regimen in our center is a tailored, finally, low doses regimen. It may be subjective and sufficient, but it's clear that it reduces bleeding. It's, for me, and according to me, the first step for prophylaxis in countries with limited economic resources. And something other which is very important, it is the involvement and the commitment of the health professional care in order to have a team with a family and with a patient. Prophylaxis now, we all agree that it is the gold standard treatment, and as I conclude in 2014, yes, the benefits is well known since the 50s and 60s, but nowadays, what is the most economical dosing strategy? And before finishing, I would like to thank a lot some of my collaborators. First of all, Professor Balqis Medeb for her support and her good advices. Kauthar Zahra, our physiotherapist, who is performing all the hemophilia joint health score and who is doing a lot of work even when it is not physiotherapy. Dr. Mariam Ashour, who joined us in the Hemophilia Center and who is involved in the team. Dr. Wajden Bourji from the Laboratory of Hemostasis, and I will not forget also to thank our nurses, Walid Hosni and Walid Bespes. And thank you for your attention.